Hemophilia is an incurable hereditary bleeding disorder that slows the clotting process. People with hemophilia experience prolonged bleeding after an injury, surgery, or tooth removal. There are two major types of hemophilia. Hemophilia A, also known as classic hemophilia or factor VIII deficiency, and hemophilia B, which is also known as Christmas disease or factor IX deficiency. Both types of hemophilia have similar signs and symptoms, but are caused by different gene mutations. In hemophilia, there is a low level or absence of the blood protein required for clotting. This causes the normal intrinsic clotting cascade to be disrupted. In hemophilia A, there is a low level or absence of clotting factor VIII, while hemophilia B is noted by a low level or absence of clotting factor IX. Because of the low levels of clotting factor present, insufficient levels of thrombin are generated in the intrinsic coagulation pathway. Depending on the degree of protein factor deficiency, bleeding may be mild, moderate, or severe. The lower the amount of protein available, the more likely that bleeding will occur. Once a platelet plug forms at the bleeding site, a stable fibrin clot is unable to form fully due to the lack of clotting factors. This commonly leads to delayed bleeding after an injury. Hemophilia can occur for multiple reasons. A genetic mutation is the most common cause. Both hemophilia A and B can be caused from inherited, X-linked recessive traits. In this case, either the clotting factor gene is missing entirely, or the clotting protein does not work properly. Other causes include a spontaneous genetic mutation during development, or an acquired immunological process where antibodies begin developing against clotting factors, seeing them as foreign invaders. In patients who develop hemophilia over age 50 years of age, there is no known cause. Risk factors for hemophilia include a positive family history of hemophilia. Males are diagnosed with both hemophilia A and B more often than females. Because hemophilia is an X-linked recessive disorder, females may carry the genetic mutation but do not generally have any manifestations of the disorder. Because males only have one X chromosome, if the mother is a carrier of the genetic mutation, there is an increased chance that a male offspring will be born with hemophilia. Hemophilia A is the most common form of the disorder, affecting more than 80% of all people with hemophilia. 1 in 5,000 males worldwide is born with this type of the disorder. Hemophilia A is also the most common X-linked genetic disease. 50% of people with hemophilia A have the severe form. Hemophilia B is less common. It affects 15% of all people with hemophilia, and 1 in 20,000 males worldwide are born with the disease. Complications of hemophilia include hemarthrosis or bleeding into the joints, bleeding into the muscles, brain, or internal organs, joint and muscle deformities, ischemia, infection, thrombosis, shock, and death. Subgaleal hemorrhage is a rare condition that can occur during traumatic labor. It leads to severe extracranial bleeding, or bleeding outside of the skull, and has a high incidence of mortality. Physical findings of hemophilia include hematomas on the extremities and/or torso, bruising, epistaxis or nosebleeds, bleeding of the mouth and gums, hematuria or blood in the urine, joint swelling and limited painful range of motion during episodes of hemarthrosis, tachycardia, tachypnea, and hypotension with hemorrhage. Diagnostic testing can begin with a risk assessment prenatally as well as genetic counseling. For prenatal diagnosis, confirmation of hemophilia can be made through chorionic villus sampling or amniocentesis. Once the child is born, if a bleeding disorder is suspected, the next step is assessment and diagnostic blood testing. Blood work that is assessed includes complete blood count, which can be normal in patients with hemophilia. Activated partial thromboplastin, or APTT, is another blood test. This test measures clotting factors 8, 9, 11, and 12. For patients with hemophilia A and B, a longer clotting time will be noted. Prothrombin time, or PT test, measures factors 1, 2, 5, 7, and 10. This test will be normal in patients with hemophilia. If the APTT or PT test come back with abnormal clotting times, fibrinogen is tested. Factor assays are done to diagnose clotting disorders and measure the level of factor 8 or 9 in the blood. If the factor assay is greater than 5% but less than 30%, the patient has mild hemophilia. 1 to 5% equals moderate hemophilia, and a factor assay measuring less than 1% indicates severe hemophilia.
Usually, the best treatment option is at a hemophilia treatment center. Teams at the treatment centers will generally consist of hematologists, nurses, social workers, physical therapists, and other specialty professionals. The main treatment for both hemophilia A and B is factor replacement therapy. Treatment is targeted based on which type of hemophilia is present. Factor replacement is given during an active active bleeding episode or can be given in regularly scheduled doses to maintain hemostasis. There are two main concentrates for factor replacement therapy. Plasma-derived factor concentrates are derived from human plasma. Clotting factors are separated from the plasma, purified, and formed into a freeze-dried product. They are tested and treated for any blood-borne diseases or viruses. Recombinant factor concentrates do not come from human plasma. They are genetically engineered using recombinant DNA technology. Recombinant factors are most commonly used in the treatment of both types of hemophilia. Remember, hemophilia A is a deficiency of factor VIII. Therefore, replacement of factor VIII is the targeted treatment. This is most commonly done with recombinant factor VIII. Patients with mild hemophilia A, usually with coagulation levels above 5%, can also be treated with desmopressin acetate, DDAVP, a chemical that mimics an antidiuretic hormone naturally found in the body to help the body release its own factor VIII from plasma stores. DDAVP can be used during active bleeding episodes and is also used preoperatively for patients with hemophilia A. It can be given IV or by nasal spray under the trade name Stymate. Use of desmopressin acetate in pediatric patients will require careful fluid intake restriction to prevent electrolyte imbalances. Again, DDAVP is only used for patients with mild and sometimes moderate hemophilia A. On the other hand, hemophilia B is a deficiency of factor IX, and therefore replacement of factor IX is the targeted treatment, usually with recombinant factor IX concentrate. Antifibrinolytic agents, such as aminocaproic acid, can also be given to help prevent the breakdown of clots, especially in oral mucosal bleeds related to dental surgery. Nursing considerations. Careful assessment is very important in all patients with hemophilia. You should assess for signs and symptoms of active bleeding, especially after an injury, listen to heart sounds, and check pulses to assess circulation. You would also ask about any chest or abdominal pain, which may indicate internal bleeding, increasing risk for hypovolemic shock. Watch for signs and symptoms of shock including weakness, fatigue, confusion, tachycardia, diaphoresis, and hypotension. Some of the nursing diagnoses associated with hemophilia are activity intolerance, impaired physical mobility, risk for bleeding, risk for injury, and social isolation. Nursing interventions. As the nurse, we would monitor vital signs and blood work, including PTT, as well as signs of active bleeding. Nurses are especially important in providing emotional support to the patient and the family. During active bleeding, you would apply pressure to the bleeding site, give clotting factor, elevate site if possible, apply ice, encourage rest, and provide analgesics for pain relief. During active joint bleeding, you would elevate the joint, perform range of motion exercises at least 48 hours after bleeding is controlled, ice packs, and provide analgesics for pain. Expected outcomes of nursing interventions. The patient or patient's family will understand the importance of balancing activity with rest, maintain adequate fluid balance and nutrition, identify ways to prevent injury or bleeding, maintain existing social relationships, demonstrate adequate coping skills, and maintain hemodynamic stability. Patient and family teaching. Parents and children of appropriate age are encouraged to learn how to give clotting factors at home. Nurses provide education about how to start an IV and the correct administration of the appropriate clotting factors. Nurses must also teach the family about signs and symptoms to assess for an allergic reaction to the replacement factors. Wearing a medical alert bracelet and educating teachers or caregivers about the disease can be very important, especially for preschool and school-age children who spend more time away from home. Teach parents to avoid aspirin or aspirin-containing over-the-counter medications. Acetaminophen should be used instead. Educate the family about the importance of good dental care to prevent bleeding of the gums. Patients with severe hemophilia may need central access ports, so it's also important to teach the patient and family about flushing and maintaining the port. Review the importance of maintaining a healthy weight. Increased weight can increase strain on joints and increase bleeding risks. You also want to teach the patient and family about the benefits of proper exercise. Swimming is a great exercise for patients with hemophilia because it strengthens muscles and joints without overstressing them. It is important to avoid high-contact sports which can increase the risk for injury and bleeding. With our continuous support and care, these children can live a happy and relatively normal life despite their disease.